And so it is my great honor today to welcome Dr. Ebbin Dotson, who is an assistant professor in the Department of Health Management and Policy, the faculty director for the University of Michigan Summer Enrichment Program, and the director for the Health Equity Leadership Pipeline Collaborative at the University of Michigan School of Public Health. Dr. Dotson's research topics include organizational theory and behavior, health equity, leadership competencies, health professions pipelines, workforce diversity, predictive assessment, health literacy, and community health. Before joining the School of Public Health here, Dr. Dotson served as the Assistant Dean of the Office of Diversity and Inclusion and an Assistant Professor in Community Health Sciences at the University of Illinois at Chicago School of Public Health. He received his PhD in Health Services and Policy Analysis from the University of California at Berkeley, and earned a Master's of Health Service Administration degree and a Bachelor's of Science degree in Organizational Studies from the University of Michigan Ann Arbor. We are greatly appreciative of Dr. Dotson agreeing to do this bioethics grand rounds and look forward to the opportunity to learn more about his work. Thank you, Dr. Dotson. The floor is yours. You're on mute, sorry.
I always do that. Everyone has to do the unmute thing in the beginning. But thank you, Dr. Spector Baghdadi. I appreciate you, and I appreciate the Bioethics Grand Rounds and the Center for just having this conversation. I nerd out a lot, everyone, around health equity, but I am very much interested in the managerial side of it. And it's not something that I believe we talk about all the time, but I think the research and I think the debate and conversations in our industry are getting there. And so I welcome the opportunity to have this conversation with you and everyone here on the webinar. I welcome the conversation. And so I'll try to speak for just a little bit of time, but I want to sort of give the impetus to this conversation, which is I really wanted to know, how do you value health equity in the healthcare environment? I want to know what the value is. So I always ask that question. So today, as I get the slides going, I wanted to have at least a conversation with us here around what would it look like if we really had this idea of managing health equity. And I put the words together, not a wordsmith at all, but managing health equity is with three unique concepts, but I want to hit on what's the idea. And so I'll try to share a little bit in the time frame that we have around just my musings on this idea of managing health equity. I work at the University of Michigan School of Public Health in the Department of Health Management and Policy. And the awesome thing about that is I get a chance to ask questions around health management. I get to ask questions around policy. And one of the ways that I do that is through a research collaborative. And we call ourselves the collaborative. We are the Health Equity Leadership Pipeline Collaborative. And we try to look at the intersection between leadership diversity enhancement, healthcare capacity building, and health education programs. And for me as a director, I just get to ask many of you, can you participate with us? Can you work with us to solve one of these problems? And health equity and managing health equity is actually one of them. And there are several colleagues that along the way that I'll try to shout out, because the way that we all ask questions, collaborating to get to that end, or at least an answer or solution, is really awesome. It's really fun. And I appreciate being in this space. And so today, if I want to play on grand rounds, I want to round with us today, right? And so if we're rounding today, there are 2 or 3 things that I want us to talk about. One is, let's get past this idea. What's the big idea? If we're going to manage health equity, how are we thinking about these big ideas around doing that? Because it seems like a lofty goal. In my writing, oftentimes I say I can achieve health equity, and the first thing someone says is, you can't achieve it. You can attempt to achieve it, but you can't achieve it. I'm an optimist, so I hope that at some point we will achieve it. But I just have big ideas, and these are grand rounds, so we can have big ideas today. The next thing I'll go through is some definitions. I want to talk about this idea of population health. And for those of you who are history majors and history buffs, I won't take long. I really won't. But we do need to have a little conversation of where historically our country has taken us, and globally things have taken us around health equity, and here health inequity. And then there's a healthcare term that many of you may have heard, but it's what gets measured gets managed. And I want to talk a little bit about what we measure and what gets managed in context of health equity, just briefly. And then I want to leave us with some discussion ideas. I will not try and give us a quiz at the end or anything, but I do want us to have some discussion ideas. And I'm sure many of you will have them as well. So the first big idea, how do you explain health equity and this desire or need to even manage it? Health equity is an idea, it's something good that we do, but it may not for everyone become a managerial practice, a business practice. And so I put this up here, one, because I like Betancourt as a researcher, but the other one is these 5 sort of statements explain what some healthcare leaders think of this idea of addressing health disparities or addressing health equity in context. And so here, just give you a quick background, there's a program called the Disparities Leadership Program. It's been in existence for a decade plus, and it brings in executives from around the country for sort of a year in residence, maybe a fellowship, and they just try and bring healthcare leaders together to say, do you understand how disparities run in your systems or in your hospitals or in your organizations? And what can we do collectively to address it? And so at the end of all that, in one of these wonderful evaluations, these leaders, these cohorts of leaders say, when you want to explain this idea of how do you or how to address disparities, how to move along the line of achieving health equity, there are some things you need to know. And they gave 5 sort of areas or dimensions to talk about when you shape this conversation. One is you have to know who to involve. If you're going to have the conversation, if you're an organization, providers, if you're looking to solve the problem or jump into the commitment to solve the problem, you have to know who to involve. The next thing they said was you have to shape organizational culture. When I hear that, I hear politics. I hear there's credibility and commitment and some other things that you need to do, but you really have to be able to shape organizational culture if you want to be in this conversation. And as you're doing that, there's this sense of creating urgency. There's a sense of saying it's not just a good thing to do, but it's a necessary thing to do. And I hear the word imperative. And I think today, and we're not at today yet, but I think today when we hear anti-racist pedagogy, we say you actually have to have some urgency and action around changing things and not just talk about it or know that it's a good solution. But this conversation has been going on for years. And then from that, they said, engage your organization and engage your audience. And that's a partnership conversation. And what I hear, I went, yes, I love this. This is a partnership. They're talking about you need to leverage and engage those partnerships. And then the last thing they all said was harness the power of collaborative work and collaborative networking. And I went, exactly. This is kind of what a lot of individuals who are now considered health equity researchers 10, 20 years ago, they were just really trying to help everyone else collaborate towards this big end, this big ideal. And so I bring this up as one of the big ideas because healthcare leaders are trying to answer this question. They've been doing this for a really long time. And when we think of managing health equity, I think this sort of captures a little bit of how and what and why we try to get there. And so in my own travels and in my own research, there's the modeling that I just, as a theorist, try to get to and get through. And this is kind of one of those visuals, one of those depictions from a forthcoming paper where we're just talking about health equity. And I'll mention it here because I think this is the end conversation, but I'll mention everything in the beginning. in case you want to go. After this slide, you can go, but not until this slide is over, right? So when you have the conversation of what does it look like to manage health equity, there are 4 general principles and ideas that I'll throw out to you, and hopefully in the end we can have a conversation about each of them. But every organization has to define health equity for themselves. And they have to define it in a very specific way so that leadership can engage and then make decisions. And as part of that process, the second step here is every organization has to do some soul searching. You have to have a self-assessment of what you contribute to the field and actually what you contribute to inequities. And that's a tough conversation for many organizations. We do, you can do self-assessments all the time, but a self-assessment on your impact of increasing or perpetuating or sustaining health disparities or sustaining social determinants of health, that's a different place. But when you do it, you're able to then say, this is what we can do as an organization. And then as an organization, you look at your fiscal investments and you're able to align them. The one thing that I just get in some consultations is an organization says, I want to invest in health equity. And I go, great, what's your prioritization? And they don't necessarily have one. They just want to do it. And I would say, you have a couple steps to go before you get there. And so realigning your fiscal investments in a prioritization way, that's an important step. And it has to happen in some way, shape, or form. And then the last one, leveraging community partnerships. And so in this way, this model to me helps me engage with other research, engage with stakeholders around managing this idea of health equity. And then the other big idea becomes, is there a set of questions to ask to know when you're ready? And I don't know the answer, maybe you all do, with the questions or in the chat, I'll start chatting and asking you questions, but are these the right questions to ask? And as we think about this in a grand round fashion, if you're going to invest, is the initiative going to result in improved care? Right, providers, your clinical perspective is, I'm spending my time trying to improve someone's care. If you ask me to do something and it doesn't directly benefit, I'm not sure if that's the right investment. I'm not sure if that's the right thing I want to champion and sponsor. Another consideration or question is the improvement, if you're going to invest in health equity, is that improvement part of your core business? Is it core business for what you do? And that gets back to sort of defining, but it gets to the other side of making sure that you've done that assessment. And then I think a set of leaders and providers will say, is there a business case to be made? And I would challenge you and say, there's always a business case to be made, but by whom? Who's actually benefiting from that case? Who are you looking to maximize in your system? Is it your patient population? Is it your bottom line? Is it your savings? The business case is important, but it's important in context. And then the piece that I think we often forget or becomes difficult for us to have a conversation around is, what are the non-financial consequences? And many of them matter. Because sometimes as an organization, as a healthcare organization providing services, you go, I'm taking care of people. I'm like, yes, you are. Sometimes it costs money that you don't get back in return. Communities know this all too well. But we have to understand that sometimes there are good consequences that aren't financially connected. And I think the good leaders who have financial responsibility and accountability say, I want to be a good steward of resources. Sometimes it just takes money to do the right thing. And that's a hard sell if you're really and only focused on the business case. But given that perspective, those are the big ideas. And thinking about these big ideas, we go into a conversation around what does it mean to talk health equity? And for those of us who are health equity scholars here or anti-racist scholars, I want to say I'm going to go quickly. I'm going to go quickly through some definitions, but I think it's important for us to know where we stand when we talk about certain things. And so when I think of health disparities, I'm looking at population-specific differences, and I'm just looking at them as indicators. When I think of inequalities, and someone catch me because I'm going to mix up inequalities and inequities at some point, but I try not to get tongue-tied. But when I think of inequalities, that the next step or the next level is differences. We start to look at them as unfair, and we start to look at them as actually avoidable. And we start to look at some systematic problem happening to create them. But then you also, with equality, you have to have the comparison groups. And we're just comparing groups in the same population or around a specific set of sort of profile characteristics. And so inequalities, I'm doing the same thing or looking at the same thing and saying something is systematically wrong. It should be avoidable. I'm not sure what it is, but it should be. And it's probably unfair. And so I take that inequalities, and then I take it up a notch and a level, and you say, right, those differences, let's become very clear that those are differences in health status. They're differences in medical treatment, not just outcomes, but health status. What's your health right now? How healthy are you to go and enjoy your life? Or what medical treatment is available to you? And that unfair part of the inequalities becomes unfair to a certain group of people. And it's a disadvantaged group of people, right? It's still avoidable, but it's a disadvantaged group of people. And so that's when you get to the inequities piece. And so hopefully we're norming here. I just want to say that you move from disparities to inequalities to inequities. Those things matter in how you frame your achieving health equity and absolutely how you frame managing health equity. So if I put out a definition and I sort of held your face to the fire and said, do we capture the right things when we think about health disparities? And then just starting back to the definitions, when we think about how and what we do when we hear the term disparities, can we do something with that? And so wondering here, if I put up a definition, this is a population health focused definition. And this is from a public health department leader and researcher. And he sort of says, he and his team say disparities are the result of differences in life experiences, right? They're differences, and it's the context in which people live. And it has a lot of things in it to unpack, but it's trying to give you the imagery of what that person lives. And so the disparity exists. And this is the public health, population health focused version. Whereas I think this is one of my favorite versions of health disparities, where it tries to break down some of those connections. And in breaking down those connections says, if you look on the far right and you say, we know what health disparities are, we know what the definition says, but how do we get there? Well, you start on the left-hand side and you say, well, you have quality of care. Two people walk into, it's like a joke, two people walk into a hospital or healthcare organization to get services. They have equal access to care and they're looking for quality. One group gets better service and quality than the other group. And if it's white and people of color, why is there a difference? If they come in with equal access to care, it's sort of the same issue, right? Simple. The difference, I would argue, in providers here, I want to say this to you, and hopefully you get a lot of love here. I want to say that when you think of the difference, when you think of health disparities, I don't readily jump to the clinical aspects, the clinical issues. I don't readily jump to, well, the preference, and so that ended up changing their treatment. I don't. What I jump to first is there was something happening when they walked in the door of that brick and mortar place, the operation of the healthcare system. There was something happening when they addressed the providers and the clerks and the specific people and what they thought about providing the care. And there's something in that system that creates a difference in the care episode. And so I would say those two aspects, the actual system itself and then the people in the system, I would say those are the two places that we want to point fingers at. And that does include providers, that does include us as public health professionals and healthcare practitioners, but it's somewhat in our bias and it's somewhat in our stereotyping of populations. And it's somewhat in the uncertainty of healthcare and what we do with that. And I'll say that uncertainty in healthcare, what we do, we really saw that during COVID. And we saw that during COVID because the uncertainty of what to do there were certain populations that ended up getting the short end of the stick. When it should have been something very similar, we should have had the operations in a certain way, but there were populations, because of the uncertainty of what was happening and the resource scarcity, somehow, some way, certain groups, certain populations ended up being at the short end of that stick. And so understanding that this other definition, and this is a Braverman, Paula Braverman definition, when we think of health equity, achieving that and moving the next step from disparities to equity, we're trying to get this language down that everyone has a fair and just opportunity to be as healthy as possible. But it requires a bunch of things. And it requires addressing the poverty, addressing discrimination and consequences. And I don't know all of the healthcare organizations that we all belong to today, but I'm not sure if your organization can end poverty by itself, end discrimination by itself. But there's a powerlessness in the healthcare environment, but we do want to do something. And so achieving health equity, I somewhat agree with those individuals who review my papers to say you can't achieve it right away, but I get what they mean. It's a difficult thing to do on your own. It's a difficult thing to do as one health system. But I think ultimately we want to address some of those disparities. And I think ultimately we want to focus on those marginalized groups, right? When we think of defining inequities. And so the last thing here that I would say is really key and really important for our conversation is that health equity can be viewed as both a process and an outcome. It kind of has this double life. And so we know there's a process of doing health equity, but we know health equity is something we also want to achieve. And I think both of those things matter when we talk about managing it. And one other thing that I'll put together here is, I'm not sure our average age here of everyone on the webinar, but let's just say, because I have gray hair, our average age is, 30 plus, 40, no, pushing 50, anyone? Okay, well, the average age of the group that wrote this definition, or at least these tenets of the definition, was about 20, 21. Nothing older than that. The average age is probably right there about 20. And I did this exercise with the group and I was so fascinated because when they said, here's how we define health equity, and there were 20 plus students in a room over an entire day having this conversation after being trained over weeks. And they said, health equity is when everyone has the necessary resources to achieve their best health. They also said the barriers that cause these disparities and disparate access, they're eliminated. And they said the system, the healthcare system that we use to pursue health has to meet the individuals and communities where they are. Right? I thought I was just sitting there listening, taking notes and everything, but it was groundbreaking to me that our youth said, this is how you actually do it. And so what we ended up doing was we adopted it, we took it. Yes, we did. We adopted that definition and said, as we march on, this is what the definition and our definition and what guides us, because it was so simplistic and direct in ways that my research mind doesn't work. And I was so appreciative to have those students engaged in that conversation. And so now moving past the definitions, the broad ones, I want to bring up just one more concept, and this concept of accountability. Because if we're going to manage health equity, you first have to be accountable. So if you're in an organization and we're talking management 101, you're accountable and you're responsible for some aspect of that organization. And so accountability, when it comes to your commitment to health equity, process, procedure, it's an outcome there, and you take responsibility for those activities. And I just want to put that out there and park it somewhere, because if organizations are going to actually manage, and now I'm getting on my high horse, but if you're going to manage health equity, and in this conversation I've had over and over again, many organizations and leaders want to do it, you have to have the culture. You definitely have a culture. Michigan Medicine has a culture. University of Michigan has a culture. School of Public Health, we have a culture. And that culture is based on the attitudes and the stereotypes, right, that affect our understanding. It's that other element of health disparities. It's not the operations, nor is it the general protocols of care or protocols of research or education. It's the people. And when we come in, we have attitudes and we have stereotypes, and that affects our understanding, our actions, and our decisions. And anti-racist researchers, please don't get me just yet. Sometimes it's unconscious. Sometimes we do it and we don't realize what our value sets are. But it doesn't qualify us to not do anything because we're accountable. Okay, I'll leave that there. So then the next thing I'll do here is just get us to a place of understanding in the population health sphere. Where have we been with understanding and talking about health equity? And I want to sort of anchor it to population health. And I'll say that in the early days, right? Again, our average age, but in the early days, a decade or two ago, when we were talking about health disparities and it's present and everyone uses it and rolls off its tongue, and health equity wasn't rolling off many of our tongues in the same way, we were talking about population health. And I have this visual of population health. One phrase has population health with the large P, and one has population health with the small p. And population health with a large P describes a large set of people. Geographically, we'll say it's a state, or it's the United States in comparison to other states. It's a disease state overall, right? It's the health service research aspect of this could be. Whereas population health with a small p describes smaller sets of people. It's Metro Detroit. It's the Ann Arbor College Town area. It could be the east side of Detroit or the south side of Chicago. Because when we look at population health as either an inequality, or we look at it as an inequity in some sense, saying there's a reason, and there's certain groups that we're focusing on that are not getting their just due, if you will. But I take that and say population health with a large P and population health with a small p, and I give kudos to one of my colleagues, Jocelyn Chisley, as he manifests this conversation all too well. But when you think of what factors affect health and affect population health at this time, people were thinking about bias. People were thinking about race and income and education and social determinants, and saying those are factors and they relate to inequalities. And we now know they actually relate to inequities. But at this conversation, we were really looking at them, but they're kind of subjective. And so researchers were trying to figure out how to make them not as subjective, but really put in some data behind what we were thinking to explain these population health differences. And quickly, I'll say that what researchers found is that race impacts mortality. And if you're looking in cancer, you're looking in other places, you can see that amongst different groups, as researchers were looking at differences, they're saying, yeah, there's a difference here by race. Is it significant? Do we understand what's behind it? And if we think about all cancers or heart disease or stroke or anything, like, we can see differences amongst groups, amongst racial and ethnic groups. And if you look at today, we're still asking that question, and we're still wondering and saying, wow, race does impact mortality and even morbidity. We're thinking about this and we've been thinking about this for years, but we're still seeing it. And we're seeing it in ways where, and in places where we shouldn't. And COVID-19, again, helped us see where some of our biases exist, and where some of our uncertainty and where some of our stereotyping exists. Because if you think about the cases, I'm not the clinician in that way. I assume that the way COVID spreads, it spreads. It doesn't discriminate. But somehow the cases were. Hospitalizations, who gets sick? Maybe it's based on who you are. It could be based on where you live. But for some reason, there's a big difference. And then when it comes to death, there's a big difference. And it's a significant difference here in the risk and the rates here. Another way you think about this is not with just race, but also with income. And you think about the cost and the cost of care, and you go, oh my goodness, what happens if it costs one person more to get healthy, for their health status to rise 1, 2, 3 points, whatever it is? And if you think about a large population of us, those who are now Medicare eligible, you just go over years, and this is an older source, but over years, we're just seeing some differences in Medicare costs. Why are certain groups experiencing, after discharge, higher cost of care? Medicare wants to know because somebody's footing the bill here, right? And in reform, we started thinking about readmissions and readmission rates and sharing risk around that so that providers could do a little bit better in managing the people that come in and managing the costs and the savings for that. And I think we're doing a good job. But years ago, not years ago, decades ago, we're looking at this and wondering, why is it different by race? And when we think about income, we go, why does income matter for health outcomes? Not sure, but it does. Whether you're looking at blood pressure, you're looking at asthma, or even chronic disease diabetes in that sense. There's something there, right? Not rocket science for many of us, but we know it exists. The other thing is that education comes into play. Why is it by education, not just income and not just race? Why are these things there? Why is there this relationship around health outcomes? And now considering achieving health equity, when we look at these demographics, when we look at these dynamics. And I'd say that there's an enduring relationship that exists between race, income, and education that we don't always talk about. We know it exists, but we're not necessarily solving for in that one. And I'd say solving for in, we're looking at some things like life expectancy. So back to mortality and morbidity, there's a significant difference between two of these groups. And one of these groups with all other three groups, right? We can see that race and gender and some of these other precursors are impacting life expectancy. So they're actually hitting home, and they're hitting home in ways that many of us as researchers really do want to know and really do try to address. How do you manage it, right? And in Michigan, when you think about what has happened over the past 2 years, I don't think that we're any different than any other state to some extent. But when coronavirus and COVID-19 first started, we were in awe at cases. We were in awe at rates of death. And today, we know that we're still going up and down depending on which variant of COVID that we're experiencing and where it is in our country, right? And so understanding that, we still haven't solved the problem, right? Anti-racist researchers go, we haven't answered the problem because we're not acting. I agree, we're not acting. Healthcare organization leaders, there's some management that we all have to do. And what would be the cool idea if we were actually managing it well? So it's still there, almost there, everyone. And so if we're rounding, we get to the last component, and that last component is what gets measured gets managed. Healthcare term, I think, could be. But what gets measured gets managed. And what I mean by that is, if you and I are looking at that specific situation and issue, and we're calling it a problem, then there are some really smart individuals, plug, who are trained and graduate from the University of Michigan and the Department of Health Management and Policy, who really focus on the business aspect of healthcare. And they're super smart. I had some of them in class. They're super smart. And what they're going to do is, if you tell them that this is measured and you need to get to a different state, they're going to make sure they figure out a solution for that. And so if they're looking and they're going to find a solution because they're really smart people, then what gets measured actually gets managed. And so let's put those data, let's put that information out there to say, if that's the way you see it, let's look and measure the value of avoidable mortality, right? We're still talking about making the case, but we're making a case for management and management of health equity, which would be avoidable and which would be focused on a specific set disadvantaged group. So if we can look at different groups, if we can look at age-adjusted deaths when it comes to breast cancer between Black and white, pick a state. The darker circle versus the green circle, I think that's blue. But pick a state, there's a difference. And this Commonwealth Fund report just came out last year. I think it's fascinating because they're talking about the value of mortality for health equity. Let's measure the impact of insurance. Those who are uninsured, we know that there's an uninsured conversation that's been around for decades. Health reform addressed this to some extent, right? But let's measure the impact of those who are uninsured by state and by race and ethnicity. And it tells us which states, if you're Black, you don't want to go to. Not necessarily you don't want to go to, but and the way that you look at this, it's where are you most likely to be uninsured? Because we know what uninsured means, or some of us do, and you can tell the rest of us. But if you're American Indian, Alaska Native, I'm not sure if there's a state that does it well when it comes to insuring you and making sure that you have the proper access to care. Achieving health equity is tough, right? But if we're going to manage what gets measured, look at what we can measure. And if we look at the influence of income, and this graphic talks about those adults who went without care because of cost implications by race and ethnicity. Who's making these decisions and what state are they in? And what are the issues in that state where someone has to make a decision on healthcare because they don't have access, because they're probably uninsured or underinsured, right? So if you can measure it, then you should be able to manage it. And again, if we think about those who are eligible for Medicare, and we kind of see where's the most activity? And where's the most avoidable emergency department room visits, and what states are these? And if we're looking by race here, not ethnicity, but by race, what are we seeing? But if we're measuring it, we should be able to manage it, right? And if we just talk basic things like prevention, from School of Public Health, prevention is key. Not looking at COVID, because it's a very specific thing that we're dealing with now, but if we just think about this idea of flu shots, you know, that's a virus, that's a prevention, that's a vaccine that everyone's okay with to some extent. But where do we see the best prevention? And what's happening in those states versus where we see the worst? And what does that mean? If we can measure it, then we should be able to manage it. But we did see with a new vaccine in COVID-19, that there's a lot to be reckoned with. Now, I'll end this part here with home and local, where some of us are. And my geography around Ann Arbor isn't that great, even though I'm a Michigander, but it isn't that great. But I look at this from the Washtenaw County group and Poverty Solutions. A shout out to Poverty Solutions here. It's a map, and the heat map sort of says that this is an opportunity index, and it talks about opportunity for equity and equitable engagement. And it has 16 different indicators. These indicators include health, job access, economic well-being, education, training. Where do you have better opportunities? And if you're seeing it and you're kind of getting in and you're an awesome map reader, then if you're in a dark blue, go blue. That's a very high access to opportunities. If you're in a dark red, that's a very low opportunity. And since it's somewhat primary colors, you go dark blue to light red to dark red. And I'm not sure if any of us are surprised with some of these areas, especially if we live in some of the areas that it may be associated with other things like race, income, and education. And so I leave us here in conversation because I think our discussion, the discussion around, is it possible to manage health equity? And I think the answer is yes. But what are those ideas that we have to reckon with, that we have to come together and understand? There are a lot of areas and a lot of places that we can go. One of those places is accountability, right? I mentioned this before, and I'm leaving it with you again. Layers of accountability, whether it's professional, economic, political, someone has to be accountable for this change. And organizations, healthcare organizations, there's a lot of data and information out there for you to utilize in order to get on that train. I also think that when we look at determinants of health, social determinants of health, that there are some upstream and downstream things that you need to do different, and we can do different, and we can focus on differently. Those 3 difference at a time. But there are areas that we see certain things, and not every healthcare organization can address income issues for their patient population. But they can partner and they can get together and they can focus on some of these collaborative partnerships. They can invest in relationships with schools with their patient population. They just haven't. But these are upstream determinants that impact that downstream care. And I think in the state of Michigan, we are trying to do a really good job of addressing things such as bias. It's a really big issue. Because if you think about disparities and health disparities, and if you believe me, that health disparities are related to the organization, the system itself, and then the factors that people bring to work to care for people, bias training is important. And the state of Michigan said every healthcare provider has to be trained to some extent by June of this year. I think that's a great step, and a great step in the right direction. And then the other place where I'll leave us is understanding that we're complex and we're complicated human beings. And this is 20 years old. And McGinnis said a long time ago in health affairs, I mean, there are a lot of things that end up killing us. But for those of us who don't want to leave early, these are some of the things that we're seeing have an impact on early deaths in our population. And whether you agree or not, it's complicated. Medical care providers, if you believe this one, 10% of what you do causes an early death. It's not that bad. But if we think of our behaviors and our lifestyle patterns, the social environment, we're getting to a majority part of this pie. We look at environment, we add that in, and these are things that may or may not be within our control, but they're important, and they're important context for us. And so how do we address some of these things as we think about how to engage in achieving health equity and how we manage health equity? And so I'll end with the beginning and begin with the end, right? I think that a basic way to model some of this conversation and answer many of our questions is, do you have a management model when it comes to health equity? And you organization, you system, you institution, you department, you community, like, do you have a model to manage health equity? And in our paper, we talk about this a lot, but we get back to these 4 simple, simplistic areas, these components. And then we use this as an actionable step, anti-racist researchers, because if you can't say that you're going to eliminate or stop something, and you can't say that you're going to address something, then you're not anchoring to a solution. And in the social cultural context of this, in order to redefine, you have to focus on a solution. And in order to assess, you have to focus on a solution. And if you're fortunate to have those resources to align, you kind of need to know what the end is that you're going for. And what healthcare organizations are learning about large-scale efforts is they can't do it by themselves. And so there are many examples of organizations trying to partner with other organizations, because remember, in the beginning of our big ideas, those leaders say you need a network. And that's been true for decades. We're just now starting to try and get those economies of scale with resources, but it's the right step, okay? And so I know I'm at time, but when I think of accountability, I also think of when you're in a position to make providers or to mandate providers to do things, federal government, or you're in a position to make organizations meet certain goals, healthcare leaders and executives. I think it's important for you to know that you're accountable. And in healthcare, you're accountable. And I use this graphic of this individual often when I say, is he safe? Is he not safe? Because there are certain people amongst us who go, we need you to be accountable. And when you think about health equity, right? Equity being there's a underserved or disadvantaged population that we're talking about. Oftentimes, when you look at this person, first off, you go, something's wrong. It's a man in a mask. It's a Black man in a mask. But if some of you are astute and you're looking at this and you have spirituality or religion in your life, you will look and say, wait a minute, this person has on a scarf, but the scarf says a few things like peace and Messiah and King and Lord. This may be someone who's in faith-based work. And not that that qualifies him to be more or less dangerous, but it's our perception and our stereotypes of certain things. And I think healthcare has to be accountable for our perceptions of certain things, okay? And so looking at this and not wanting to scare anybody, so I put it really small, organizations are political. The goals are complex. The participants are motivated by certain things. The organization is an asset, but it has resources. And those relationships that we have, that we use, that power stems from certain places and stems from many resources. And I'll say that if we're going to manage health equity, here's the answer in the joke, we have to actually manage ourselves in those organizations. Because if we get to that point, management becomes that much better, and those 4 steps of that model become much easier. And so I hope that we all, I know this is the grand rounds, but I hope that we all get to that point and get to that outcome. And so thank you.
Thank you so much, Dr. Dotson. That was really excellent. I know I have never seen health equity being taught from a management theory perspective. And it was really helpful to me sort things out in my head, and I'm sure for many of the rest of us. That was really great. Thank you so much. We definitely have a couple questions in the chat. I also wanted to ask one just sort of to kick us off. So many of us are bioethicists at the Center for Bioethics and Social Sciences. And I was wondering, I'd be really interested in your thoughts of potentially the role of bioethics in either supporting some of these changes. You know, as a center, 2 of the main things we do are offering like a clinical ethics consultation service to patients and families and providers, as well as research on bioethics. And so I was wondering if you had any ideas of things that we could do as bioethicists to support this vision of yours.
Well, I thank you for that question. And I would say jump in, right? That's a big, broad response. But here's the context, right? The context is if you're engaged in healthcare services, if you're engaged in consultation, you're engaged in direct research, it's hard to have the question around stereotypes. It's hard to have the question around what is our role as individuals, as people. And I think that bioethics has this really great context and so much great information and research that you're all able to have the conversation and discussion Discord better than many of us. Because I think for me to do something like this, right, I need 30 slides to try and prove that this is an issue. Whereas I think the way you all approach it is just a little bit different, a little bit better. So I would say in context, have more of these conversations not invite me, invite more of my colleagues, to the conversation, to the table, because I think you're seen oftentimes as a group that has the sort of not the scientific background to really understand some of these conversations and how we behave and how people act in a way where it's not as if I'm coming at you, right? As a management person, I'm coming at you because I want to save money. I think you all have a different perspective on this, and many of us would probably come to the table so much easier feeling that in tongue in cheek that you're nicer than the rest of us. Providers go, too much work, administrators go, too many things, and the system. But I think the way you all approach the conversation is better, and it's nice. And so I would say being a place where you can convene these kinds of conversations, I think we could get a lot of traction from that.
Great. I'm not sure everybody feels that way about ethics, but I'm really glad to hear that you do. So we have a lot of great questions. I'm going to try to combine a couple of them. So in your management model, sort of the base of the management model was engage with leadership, and the top of the management model was engage with community. But two questions related to that. What if leadership doesn't want to, what if leadership doesn't ask the question to begin with, which I know they are if they're hiring you as a consultant, right? But what kind of community can make them ask the question? And then what about sort of, I don't know the right analogy, but like the pool of water around the pyramid, like Michigan Medicine with all of those other people on the map that don't present as patients, but potentially we should have some responsibility for it.
Yes, accountability. Everyone say it together, accountability. So I'll give a story and make sure in the group here that no one in the chat is from that place right now. So I give the story conversation. It's the middle of COVID. It's probably June, July. So it's just happening, and it's just going, and we are all unnerved, and we're not safe. We don't feel safe in anything that we do, right? 2020. And I get a call from, this is also, to park it and put it in place, this is also where we're seeing a lot of conversation around racial equity, racial issues, racial problems. You have these two firestorms. One would be the physical safety within COVID, and then the physical bodily safety within groups of people, and African Americans and Black people. And you're hearing all these problems and issues. And so the healthcare environment goes, wait, publicly, we have to be able to say that we're for this other group as they're having this problem because they're our patient population. And these leaders go, how do I manage the fallout and manage the issue? Telephone call, major organization, leaders in a major organization, and they go, what's the best way for us to commit publicly around dealing with issues that impact people of color, as well as to address our mission and bottom line, because we're losing money, we can't have anyone do all these other things. And they said, what can we do? My answer was, if you're going to get at that first level to really redefine health equity, you need to make sure that you have people at the table who can actually redefine health equity. And I said, organization, what does your board look like? What does your governing board look like? Does your governing board look with race and ethnicity and gender like you need a lot of help? And many of them went, yes, oh my gosh, yes. But so do we hire, or do we invite, do we bring more people on the board? I'm like, yes, you need to bring more people on the board who can then redefine your health equity conversation at the bottom. And then that allows your leaders, right? Because a lot of times in these major organizations, the board hires the executive, and the executives are pushed by the governing board or the board of directors. And so it's a real nuanced, weird way that we don't always think about, but from our management lens, we do. We say, you need to have the right people at the table to redefine, because your CEO, your president, your executive may not directly think about that, but we are. And we understand that what gets managed gets measured. And if their compensation and their business acumen is based on redefining health equity and jumping into that commitment, again, really smart individuals from our program at the School of Public Health and Health Management and Policy, and they are out in the field leading healthcare. You give them a goal, they're going to achieve that goal. but you have to be strong enough as a board to say, executive, this is what we want you to do. So that first part of it would be, you have to have the right people push the leaders to do it in the right way. I think the second part of that one is the other piece of the model. And the other piece of the model kind of gets us to this conversation. I'm showing it up again, everyone, but the leverage the community partnerships of the model gets us to, you have to create some sense of shared ownership. And those people in the water, they're going to need this healthcare environment at some point, because we all do, right? And so at some point, that organization said, oh my gosh, it's not my workforce, it's the people where my brick and mortar buildings are. It's the places where my employees go to get food and other things. So we actually have to do things that look like we're supporting our community. And so I think that community partnership, we saw that as well during COVID, where you had so many organizations coming together to try and just do things like even provide PPE and other things like that. But you have to know that that's important and not just good to do. And that's where I think that realigning your fiscal investments, that's where that really does come into play. But both really good questions.
Yeah, no, those are great points. So I would love to keep you another hour to answer all of the really important questions in the chat, but unfortunately I can't. But so I guess what I will ask of you is that amazing article that's going to come out. Would you send that to us, and we'll make sure that all of our colleagues on this call get it? Because just from the amount of people who have come and the amount of people asking questions, I know that people really want more content here. So we would really appreciate that.
Absolutely, yes.
Yeah. Thank you so much, Dr. Dotson. This was